Hello, everyone. Welcome to Neurospicy Nursing. It's your ADHD-friendly study buddy, helping to turn nursing chaos into clarity. Today, we're going to be going over some of the nutritional management, cultural care, and safe medication, stuff like that, as well as the skin assessment. All right. So when it comes to nursing as a whole, um, in the state that I live in, there are, and every state really has them, there are nurse practice acts, which basically tell you what you can and can't do as a nurse in your state. And then there's other things like the FDA, which that's more for drug trials and stuff like that, as well as our safety reporting. Um, and we have our Controlled Substance Act. We also have these are all for pharmacology based, right? But there's also, and I am gonna butcher the name, but there is something called um there is a joint commission, and there is also the Office of the Inspector General, and those are also part of that regulatory mandates and stuff like that. And then we have our ethics. You guys have heard them all before. Autonomy, beneficence, non-maleficence, that's the specific one for do no harm. That one's very important. Justice and veracity, so making sure we're telling the truth. So, one thing to note, whenever there's a med error, even if the pharmacist makes the dose mistake or if the doctor makes the dosing mistake, if you are the nurse, you administer that medication. The nurses administer, we don't dispense unless you are a community health nurse. You administer that medication, it's your fault. So that blame is going to be put on you. All right, so other things to keep in mind when it comes to drugs is, you know, polymorphism. So every single individual, a drug is going to interact with them a little bit differently, right? This is why sometimes we have to go through all of the different drugs to find what works well with certain individuals. Some drugs have historical context around them, like, for example, ACE inhibitors. If you are African American, it's more likely for you to get that angioedema than someone who is not. So that's also what we mean by historical context. Um, and then there's, the physiological assessment that we do, because there are side effects like SJS or that higher risk of sunburn for some of our antibiotics. So we have to make sure that we are telling them all of the different systems that can be affected by the medication they're taking, as well as making sure you tell them, you know, why you're taking this medication and here's the consequences of not taking it, like with art therapy. The consequences of not taking art therapy is to progress to AIDS, right? So we have the enteral and parenteral nutrition. This is kind of the same way. Think of it like how we take meds, right? It's either really going through our mouth. Obviously, we have topical and buccal and stuff like that, but it's really going in our mouth or it's IV. So for enteral nutrition, this is for people who still have a functioning GI tract, right? Like they are able to still break down the food. They don't have paralyzed intestines or anything like that, or a paralyzed, I don't know, stomach. I think it's a long story, but paralyzed guts in general. Um, but another thing too is that let's say an individual just had a stroke, and they're at a super high risk for aspiration. We can also use that for this, right? Because we're gonna put it could be like an NG tube. It's gonna bypass that like epiglottis, and then they're not gonna choke, right? Versus parenteral nutrition, This is going to be through like a central line or a PICC line. So just keep that in mind. Like it's normally specific types of lines that we're doing it in. Um, and these are very, very personalized to the patient. For like everything that they need is going to be in their little bag, right? So this is when the individual's GI tract, like I was talking before, it could be paralyzed. So this is when we would use the parenteral nutrition. So just going in real quick for the different types of terms or different types of routes for the enteral nutrition. There's NG and OG, and there's also ND and NJ. So these are all of our temporarily less than 4 weeks, hopefully, for feeding. These have a higher risk of aspiration and dislodgement. It's just a really little tube that goes down their throat. So it would make sense why. And then the PEG tubes and the J tubes, they go directly into the stomach. So through the abdominal wall into the stomach, or in the case of the J tube, through the um, duodenum, and they're more secure and they're for um, longer term. These tend to be more invasive though, just because um, obviously you have to go through the abdominal wall and then you have to worry about that stoma site getting infected. So this is PPN versus TPN. So PPN can be administered through some sort of peripheral line, like your standard peripheral line. Um, Hopefully, though, that they're not receiving this any more than 2 weeks because it is very irritable on the vasculature system. Um, but it's really just for people who, I feel like in most cases when I've seen this, the individual can still tolerate eating orally, but they're having some sort of malabsorption. So they'll give them the peripheral nutrition versus TPN. This is one that I was talking about where you need the um, specific lines for, again, because it's just so very damaging to the vascular system. And these are for people who have like paralyzed guts and stuff like that, where they're going to need it more long term because they physically can't digest things through their GI tract. All right. So going into some more of our safety stuff, and our medication administration stuff, we have the 10 rights of administration. I will tell you that really the first five are going to be the most important ones that you're going to deal with, right? And then right documentation, also very important. Make sure if the patient, it's their first time taking the medication, that your patient understands what the medication is, why they're taking it, and then you're going to give them the right to be able to accept or decline that medication. Um, for a right response, this is when you go and reevaluate them. Let's just say you gave them morphine, and because their pain level was an 8 out of 10, after about an hour, 30 minutes to an hour, you should go in and reassess that person's pain. Their pain should have lowered. However, if they're not really responding, their respiratory rate is low, that would be an incorrect response to that medication. And then right reason. So this is more checking the order and making sure that, is this Tylenol, can I give it for pain or is it only prescribed for fever? That's kind of what they mean for like right reason. And then we're going to use the antiseptic techniques and more safety stuff for the enteral feeds. Again, your gut's not sterile, so there's no reason to be using a sterile technique. Um, all of their enteral nutrition should have, you know, all of your patients' identifiers and stuff like that, and then you should make sure that you initial it and then put up the date and time in which you put it up. They should be um, sitting up to at least a 40 or 30-degree angle during feeds, and this is just to help with aspiration risk. Again, right patient, right formula. This is our rights of medications. Right tube, you're not going to put a parenteral nutrition in a G tube, right? So that's what they mean by right tube. And then trace on the lines, we have to make sure that they're actually getting whatever either medication or nutrition that they need. So make sure that you are connecting the proper lines. Enteral nutrition or stuff that's enteral normally has a purple cap versus IV stuff has a red cap or a green cap, depending on where you are. Okay, so when we're crushing medications to put in like our NG tubes or our G tubes, make sure that you're using only water. If your patient is immunocompromised, we're going to use sterile water in order to crush the medications. And the best practice, right, is to not mix the drugs together, right? Because when you crush it, it can technically adjust the pharmacological aspect of it and can because you're crushing it and now has a more rapid absorption, but it can mix with the other medications. So that's why we try to say, administer them separately as possible. But if they have like 12 medications, I would talk to a pharmacist. They're going to be your best individual for knowing whether or not if you crush them and mix them, if it is going to do something to the patient. Pro tip, so back in the days, they used to use Coca-Cola to try to unclog tubes and flush the lines. Don't do that. We don't do that anymore. And if you see someone doing that, it's not best practice, right? You're gonna let them know that. For feeding tubes, all of the 10 rights, they're still gonna apply to these patients. And then some places they have specific protocols when it comes to feeding tubes, so make sure you follow your facility's protocols. Okay, so for some more enteral feeding, this is kind of like the concerns and why we would do, or the complications for these things. So diarrhea, obviously, if they're getting it pretty rapidly, maybe they have some malabsorption stuff. It's going to cause diarrhea, bloating. Again, this is why we aren't going to want to put soda in there. It's going to cause more bloating. And also, if they're having an insufficient amount of water intake orally, that's going to also cause some issues like constipation. And these things don't really have like fiber in them, so that's another thing. There are such things as clogged tubes. Like if there was a chunk of med that's too thick, it's going to clog the tube. Or not flushing properly is also going to clog the tube. Then there's tube displacement, which is why we check for NG tubes to make sure that that is the same, like the amount of length that's out of the individual's body is still the same. And then we have, and it goes with this kind of dehydration, sometimes overhydration, hyperglycemia. Actually, I feel like hypoglycemia is more common because in TPN, at least, it has insulin in it. So you have to make sure that you are monitoring that. And then there's something called refeeding syndrome. That's really for individuals who were malnourished and now we're putting food in their body too fast. Okay. And then for parenteral, they can get a Clasby, which is a bloodstream infection from their central line. We should be using a relatively sterile technique for that catheter. Obviously, we're not going to put it in, but for access at least, there should some sort of sterile technique should be used. Also, on these lines, just to prevent the Clasbys, it's best practice to use something called Prevantix instead of alcohol. For the metabolic, I talked about that rebound hypoglycemia. If it's suddenly stopped, again, that's from the insulin and stuff like that. And then catheter misplacement. If they're a little kid, they might pull it out. And then you can end up, because it does go, obviously, it goes to your bloodstream and then into your bloodstream eventually for gas exchange goes into your lungs. So you can end up with air embolisms, like if there's air in the catheter and stuff like that. All right, so medication reconciliation, this is when a patient's going to bring all of those meds to their appointment and go over them with you. Um, so some of them have a lot, and it's just getting a full list of what medications they're taking, which ones are PRN, when they're prescribed, all of that. Okay, this one's going to be very important. We should never really recap a used needle. If you have like absolutely have to still use the scoop method, but be very, very careful. It is really not best practice to recap a used needle. Um, Really, the scoop method should be used for unused needles, and that just helps prevent needle sticks. Don't put anything in a full sharps container, right? And then if it is full, um, you know, I would say if it's a syringe, because you should be putting your syringes into um your sharps container. If it's like a flush that you just used, it's okay to put that in your pocket and go, you know, get the fresh one. But if it's like an actual sharp, um, you should have checked before you went in there. Filter needles are going to be when we're drawing up. They're those plastic filter needles are used more commonly now. But we're never going to inject a patient with that. That's going to hurt. Those things are big. And it's probably not going to even go in. Um, And then we're going to check for IV piggyback compatibility, specifically like for IV fluids and stuff. All right, so talking a little bit about that culture, right? So the systemic culture in this case. It's okay if you don't understand something to ask for clarification. Please ask for clarification, actually. And if the individual who you're asking for clarification is not giving you a straight answer or they're being unhelpful, please go to someone else. Also, for some certain medications, you're going to have to double check your math with somebody else, and then somebody else is going to have to watch you pull that medication as well as waste that medication. Also, make sure if you're giving a blood pressure medication that you're taking the BP before you give the med, because if their BP is like, I don't know, 105 over 66, I don't think that they're going to need their blood pressure medication, right? That's a pretty normal blood pressure. Um, and then make sure that if you do make a mistake, that you report your mistake. Okay, so here's the pillars of nursing judgment. And it is going to be all based on making sure that we have safe nutritional support for our patients and that our medication administration is, well, sometimes it can be an independent task, but they have different components to it, right? The other thing I want you guys to know about nutrition, for nutrition, specifically when it comes to like that cultural care, right? Food is culture. So if your patient isn't eating anything in the hospital and you're trying to keep them because you know that their GI tract works, but you guys are like, I don't think enteral nutrition really is the way for this individual, it's okay to ask them what they like to eat. And it's okay to ask family, hey, can you bring in X, Y, and Z that you made at home for this person to eat so that they can eat something? That's perfectly fine. Hospital food is really gross, right? Like nobody really wants to be eating hospital food, especially if you come from a different culture. I'm Hispanic. I prefer to eat my Hispanic food that my mother makes. You know, like if I'm in the hospital, I'm sorry, I want my bacalao. Okay, like give me that. Don't give me whatever this slop is on the plate. Okay, that's the other thing to keep in mind with nutrition. And then the other thing too is don't ever tell someone to cut something out cold turkey, right? We're gonna do reduction first, right? And to say, hey, if you eat fried foods every single day, let's first start cutting back to 6 times a week and then reevaluate. And then 5 times a week, reevaluate, that sort of thing. But cutting it cold turkey, especially if that's just part of their culture, is eating really, really heavily fried foods. I mean, we're in the South. I mean, come on, right? Like, those are other things to keep in mind when it comes to that cultural nutrition assessment. I know I went into a lot of the enteral and parenteral nutrition, but I really do want to mention food is culture. It's really better to tell them, be mindful of what you're eating, maybe, have it more in moderation, that sort of thing, versus cutting it cold turkey. Alrighty, we're gonna go over the integumentary portion now. So here's all the layers of the skin and the anatomy of the nail. I'm not going to go through it. You guys can pause the video and watch it. But just keep this in mind throughout our skin assessment. Okay. So things that we're going to look for our skin assessment is going to be whether it's CDI, so it's clean, dry, and intact, their skin texture or turgor, so does it feel leathery? Are they tenting? Their temperature? Do they feel really hot? Are they sweating? Is their limb really cold? Um, as well as like what color are they cyanotic? Are they really red? Are they pallor? Those sort of things. So it's normal to see some birthmarks, vitiligo, stuff like that. Any bruising that makes no sense on why it's there, they don't even know why it's there, that's going to be abnormal. Cyanosis, that's abnormal, especially if it's centrally. Erythema, that's that redness, abnormal. Jaundice and pallor as well. So when it comes to skin turgor, we should expect our skin to be warm and dry. And then, when we pinch it, it should pinch and then go back down, right? If it's tenting, that's abnormal. Versus if it's like an immediate, like a very kind of aggressive immediate bounce back, or like you're having a hard time, they could have fluid overload. So another thing, um, with that fluid overload, that pitting edema. So anything a +1 is going to be 2 mm deep, and up to a +4 is 8 mm deep. All right, for oxygenation, when we're talking about the nails, clubbed fingers, that's poor oxygenation. Our cap refill should be less than 3 seconds. Anything above, that's a sign of poor circulation. Um, And then, really we should have a uniform colored nail. There really should be like no visible fungus, stuff like that, or some jagged nails. Here's the ABCDE guide. This is for the suspicious lesions. So it's asymmetrical. The borders are irregular. The color is not uniform. The diameter is larger than 6 mm and it's evolving. So it was normal at one point, or maybe looked differently than it does now. So make sure that at least one time in your um, shift that you've done your full head to toe, even if you have to break it up in sections, but it needs to be done within at your first shift, like within your shift, right? At least once. And then any pressure injuries have to be documented within 24 hours of admission, or that's the hospital's fault. Okay, so talking about kind of those pressure injuries, stage 1 is going to be our hot spot. So this is when we press down on it and it's going to have non-blanchable erythema. Stage 2 is it looks like a popped blister. So they have like an exposed dermis and other skin loss, and their wound bed is pink. When you put water on that sucker, it's gonna hurt. It's gonna burn. All right, stage 3 is when we can visibly see that adipose tissue, some of that fatty tissue. Um, Normally, like, I mean, yeah, you could probably get one on your ankle, but these are going to be very commonly on your like buttocks and stuff like that from not moving around your patient. Um, or if they're coming from a nursing home, it's common to see that on their bottoms. Stage 4, that's our full thickness. We can see muscle, we can see bone. Very bad. Um, very, very bad. They need extensive medical interventions for those. So we have an unstageable injury. So they either have slough, which is that yellowish, really gross looking, like pussy like tissue, versus eschar, which is that necrotic tissue. They have to debrief that in order to get a full um, stage. So it's unstageable until they debrief it. And then there's the DTIs, which it looks like a bruise, it's almost like a hematoma, but it's a really intense, like purple discoloration of either intact or non-intact skin. Here's just some common places where we're going to be able to see pressure injuries. Um, I'm not going to go through all of them. You guys can pause, but this is a really, really important chart to make sure that you know about pressure injuries. A lot of times we think about the sacrum, but it's really not just that. Also think about behind the ears, right? Like if they have oxygen tubing, that's why we should be checking behind their ears for that skin breakdown. All right, so primary versus secondary lesions. Primary is going to be, it would have developed on like previously healthy skin, like a wheal, which is a raised itchy bump. And then there's nodules, which is a solid mass. Um, a pustule, it's basically a pimple, right? And then secondary lesions. This is like erosion of the epidermis. So it could have been like if this could have been something that came from one of these other things like the papule, the wheal, stuff like that. Or they might have a scar. Like let's say they removed a nodule. They could have a scar from that. Or an ulcer, a pressure ulcer. That is a secondary lesion. One thing to keep in mind that's going to be very, very important for you to do every single shift is going to be your Braden scale. Please make sure that you do that. That is going to tell you whether or not your patient has a higher risk of developing a pressure injury. Nutrition too. When we talk about nutrition, it's super important for our wound healing, right? So talk a little bit going back to the beginning of our lecture, but a high protein diet is going to be super important for tissue repair and wound healing. So we need to make sure whether they just had surgery or they have a pressure injury, that they have some sort of protein in their diet to help them heal. And then for our pressure injuries, here are just some common types of wound dressing. Um, I really like to point out the occlusive. This is just if you guys have ever seen like a pimple patch. Um, that's basically what an occlusive dressing is. Fun fact. That hydrocolloid, it's the same as what's used in the pimple patch. All right. So for the last section of this, I think this is actually the last page. But making sure that we're telling them, hey, make sure that you are using sunscreen that's going to prevent skin cancer. It doesn't matter what your job is. Doesn't matter if you're just in your car and you're commuting for a few hours, you can still end up with skin cancer, right? Or if you just sit by a window, right? These are things to keep in mind. Make sure that you do a skin assessment, especially if the individual has a lot of moles. They have to make sure that they're monitoring those moles. And hygiene, use lotion and stuff like that. But one thing to keep in mind is not everyone has access to clean water. I know that sounds crazy. We're in 2025, but not everyone has access to clean water. Not everyone has water readily available. They may not be able to shower as regularly as maybe you do, or me. I'd like to shower twice a day. There are some areas in North Carolina where it's not feasible for them to shower every single day, whether it's financially or location wise. So make sure you're also keeping that in mind. But you can give them other, options like you guys have baby wipes. Maybe just wipe down your skin with it, right? Or use some sort of moisturizer. I've heard that tallow, I think it's called. It's like whipped beef fat is really, really big. Um, I feel like maybe don't go outside with that. I feel like that would increase your risk of skin cancer because you're putting an oil on your skin. But that's another thing that they could maybe do. Um, and then one thing I did want to mention too when we're talking about Our skin assessment is going to be the hue to orange, right? So, this is when you're looking at that breast tissue and you have like dimpling, unilateral edema, or your skin literally just looks like the skin of an orange. That can actually be a sign of breast cancer. And that is all I have for you guys today. Thank you so much, and I'll see you in the next one.